Hello, my name's Florence. Welcome to the theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter, anyone else that's interested, the theobspod is for you. Episode 148, Bladder Care. This week is a direct follow-on from my previous episode, Fluid Balance. As a crucial part of fluid balance is urine output. How are the kidneys functioning? And that goes part and parcel with bladder care. I think bladder care can sometimes be something we're a little bit remiss about, both in terms of how we look after women, but also the information we've given women. Large numbers of women that I see giving birth on the labour ward or in the operating theatre require a catheter. That is a tube placed in their bladder through the urethra, the tube connecting the bladder to the outside world, to empty and drain the bladder. And I'm not sure that we give women that much information about having a catheter, or the fact that a catheter might become necessary in certain situations or go pretty automatically along with certain choices that they might make about pain relief or particular birth options. Anatomically, the bladder sits in the pelvis, anterior or in front of the anterior vaginal wall. So it sits in the bowl of the pelvis, in front of the vagina and womb. And that's why one of the symptoms women experience in pregnancy, sometimes in the first trimester when the womb is a pelvic organ, is that desperate need to go to the toilet and empty their bladder more frequently. And then as the baby grows and develops and the baby's head is perhaps getting in position, ready for birth, again, that intense pressure on the bladder, once again, as the head is pressing down on the neck of the womb and also on the bladder at the same time. So we're very conscious that part of caring for a woman during her birth is care of her bladder. The very process of the baby descending down the birth canal can be pressing on the bladder and making it more difficult for the woman to have the sensation that she needs to pass urine or to be able to pass urine, so can cause retention, that is an inability to be able to empty the bladder. Plus, if the bladder fills up, if you imagine blowing up a balloon and putting that in front of the baby's head, that's obviously potentially going to be obstructive and difficult for the baby to move past, which in addition can cause quite a lot of pain for women if the contractions and the baby's head is pressing down on an overfull bladder. And these are things taken into consideration before one even thinks about interventions such as an epidural or spinal anaesthetic, which remove the normal nerve sensation and urge to empty the bladder because of the loss of sensation to those particular nerves that innervate the bladder. So bladder care is extremely important. So we need to think about it partly because of the fluid balance, the care of a woman's kidneys and how much fluid she is or isn't drinking and passing urine to make sure that she and her baby are in balance and in good health, as I discussed last week. But we also need to make sure that the bladder isn't obstructing and making labour more difficult, but also importantly that we're not causing any damage to the woman's bladder that could cause a longer term problem. Some women will experience problems passing urine after birth, so what we call postpartum urinary retention, and this has an incidence reported between 0.7 and 4%. And this can result from a single episode of over-distension of the bladder. On average, the bladder might contain around 500 millilitres, half a litre of urine. But sometimes when we pass a catheter in labour, we end up with a litre or more than a litre emptying straight out of the bladder. And that's the situation that I'm talking about, over-distension, where the bladder has been way too full. And this can cause longer term problems and consequences, resulting in damage to the bladder muscle or recurrent urinary infections. So care of the woman's bladder is extremely important. One of the things that we'll be doing when we're caring for a woman in labour is to make sure that the woman is passing urine, emptying her bladder every 3 to 4 hours. And we will sometimes seem obsessive about recording the amount she's passing and how often she's passing. It's also important when a woman is in a birthing pool for us to accurately assess and figure out, is she passing urine, and is she passing urine of a good volume and regularly. If a woman can't pass urine, so she can't empty her bladder, then it's very important that we should catheterise, so insert a tube to make sure her bladder is empty. And sometimes there's a misconception from more junior members of staff that if the woman is passing urine very frequently in small amounts, that is okay. Or sometimes we see a woman who seems to be passing urine when she's in the second stage, the pushing phase of birthing her baby. But actually, to me, this is a very worrying sign, because this can be what we call overflow. So the bladder is over-distended, she hasn't managed to empty it properly, and then a small bit is leaking out quite frequently. And this is worrying that she may have a very, very full bladder that she can't empty properly. So we may need to perform a catheterization, passing a small tube into the bladder, and this can be uncomfortable and stingy. We can use something called instiller gel, which is like a numbing kind of local anaesthetic gel to make it a bit more comfortable. Or if a woman has had an epidural, then actually she won't feel what we're doing. But we do need to be careful and make sure that if a woman's unable to empty her bladder, that we do regularly catheterise and empty the bladder. And if this is done more than twice, then we will leave a catheter in. So that's a small, soft, rubbery tube that sits in the bladder and keeps it empty. There are various situations where we will pass a catheter as part of the treatment. So after the baby's born, if the woman's got a bad tear, then she's more likely to go into retention and not be able to pass urine. So we'll site a catheter. If we've had to put a vaginal pack in to put pressure on a tear, again, she won't be able to pass urine easily. She'll need a catheter. Or if we're treating excessive blood loss and the womb isn't contracting down well, one of the treatments we'll give alongside drug treatment to help the womb contract is to empty the bladder, because that will help the womb contract as well. So we will catheterize in that situation too. So there are quite a lot of situations in which a woman might be recommended a catheter for treatment of something. Then we have the issue about women having an epidural or possibly a spinal anaesthetic. Spinal would be more likely if they're having a caesarean birth, but could also happen with some forms of assisted birth. And with an epidural, then the woman will not have the normal bladder sensation, and it can take up to 8 hours for normal bladder sensation to return. And therefore, it's incredibly important that a catheter tube should be placed in the bladder no more than 2 hours after having had an epidural, and then it needs to remain after birth at least 8 hours after the last epidural top-up. So if you have an epidural, you have regular top-ups of pain relief, and we need to wait at least 8 hours after the last top-up before we take out the catheter tubing, because that's when we'd expect the woman to usually be able to have the sensation and feel that she needs to pass urine. The other slightly weird thing about catheters is that you will see that when we do an assisted vaginal birth, we need to catheterize. So one of the kind of prerequisites, one of the things we need to check before we do an assisted vaginal birth is that the bladder is empty to help protect the bladder. So if a woman hasn't got a catheter, we will catheterize to check the bladder's empty, and particularly if a catheter was removed for the pushing phase of labour, and then maybe an hour or two has passed, and then we're called in to do an assisted vaginal birth, we will recatheterize, which then feels slightly bizarre, because we will then take the catheter out. And this is because if you are pushing and you're pushing the baby past the bladder, having a catheter balloon, because there's a little balloon that holds the catheter in place in the bladder, is not a good idea. And so the advice is that we should deflate. The catheter balloon is full of about 10 millilitres of fluid, and that little balloon is what holds it there and stops it just dropping out and falling out when the woman is moving. The advice is that we should be deflating, so taking that fluid out of the balloon before the woman's pushing or before we're doing an assisted vaginal birth, in case that could damage the bladder. So you'll see us catheterize to check that the bladder is empty, but then deflate a balloon and possibly take a catheter out, which always feels a little bit nonsensical. And I always wonder a little bit about what the evidence is about damage from catheter balloons in second stage and with assisted vaginal birth, because when I was younger and earlier in my career, we never deflated the catheter balloon. And I sort of find it a bit weird, because your bladder, can expand to be several hundred millilitres. So the idea that something within it that is 10 millilitres might be damaging just feels a bit odd. But that is the national guidance. So that's kind of a bit of care in labour. And that's why we'll ask you every time you go to the toilet to show us how much you've passed, or we'll record how much you've passed or how often you've been. And that's why if you aren't able to go to the toilet, we might recommend a bedpan, or we'll be encouraging you to get up and go to the toilet and try and empty your bladder, even if you don't particularly feel like it. So that's why we're a little bit obsessive about bladder care, alongside the fluid balance issues that I discussed last week, and the urine being a very important component of that. After you've had your baby, then what will normally happen is your body will start to diurese. So that means your body will start to produce more urine in the immediate time after birth. So that is, the amount of urine increases for the first 12 to 24 hours after birth. And we see this quite often. So a woman who's maybe had very reduced urine output, she's been in labour. Remember, I talked last week about the fact oxytocin or syntocinon, synthetic oxytocin, can limit the amount of urine passed and reduce it and help retain fluid, that once labour and birth is complete, we'll then start to see they diurese. So the woman will start to produce a lot more urine. The urine will be a lot more dilute and much larger volume. And that is the body's way of recovering from the birth, and also starting to undertake some of those physiological changes. Remember, in pregnancy, you started to retain a lot more fluid as part of the physiological adaptations to pregnancy. And this is part of the reversal of that. So lots of that extra fluid is being lost. And this means that women after birth are particularly more likely to experience an over-distended bladder. So they possibly can't feel properly, they need to pass urine, either because the head's been pressing on the pelvic nerves for a long period of time, or they've maybe had an assisted vaginal birth, or they've had epidural or spinal, and they can't feel properly that they need to pass urine, and their kidneys are kicking out lots of increased urine output, and it can be difficult to know when they need to pass urine. So one of the standards that is really important after you've had your baby is for us to measure the first couple of times you empty your bladder. And that might be immediately after birth, or in the few hours after birth, if you didn't have a catheter or didn't have an epidural or anything like that. Or if you've had a catheter tube in labour or had a spinal or epidural anaesthetic, then this might be at a point when you're having what's called a TWOC, or trial without catheter. Not great nomenclature, I know. Don't like the idea of a trial of anything. But what we want is to measure how much urine you can pass. We want you to try and pass urine within 4 hours of the catheter being removed. And then what we can do is measure what's called the residual volume. So that's the amount of urine left in your bladder that you haven't passed. And this residual urine, the amount of urine left, shouldn't be that much. So you should be able to pass, or a woman should be able to pass, at least 80% of the contents of her bladder when she empties her bladder. So what we would expect is that a woman, after having had a baby or after having had the catheter removed, should be able to pass urine, and should pass at least 200 millilitres or more. So we're expecting that that's a good volume and that the residual volume shouldn't be more than 200 millilitres. If a woman passes less than 200 millilitres in 4 hours, then that's concerning, that she either has retention, she can't pass urine, or that the urine output is very reduced. So we need to be careful. So what will happen is, after you've had your baby, or if you're caring for a woman that's had a baby, we would expect that she'll pass urine. Normal bladder capacity is roughly half a litre, and therefore if she passes half a litre, that's fine. But if actually she can't pass between 200 and 500 millilitres, and we can scan with a thing called a bladder scanner, and see what the residual is, or pass a catheter to measure what the residual volume is, then we will suggest reinserting the catheter. So if the residual volume is between half a litre and a litre that drains out as soon as we've reinserted a catheter, then that woman needs to have a catheter for a further 72 hours to give her bladder a rest. Whereas if the residual volume when we recatheterise is more than a litre, then that bladder has been very overdistended, and we will recommend that we leave a catheter in for 7 days, so a whole week, with a catheter tube and a bag, which is quite stressful and upsetting when you've just had a new baby, and can seem almost punitive. Well, you couldn't pass urine, so we're now saying that you should have this tube, which is uncomfortable, and this bag that you've got to carry around or have strapped to your leg for a whole week. And that can seem very over the top, but what we're really trying to do is give that bladder muscle a rest, allow it time to recover, allow time for the nerves to recover, the muscles to heal. If you've perhaps had stitches, whether that's perineal or vaginal stitches, or whether that's cesarean stitches, and let everything really settle down to give your bladder, or that bladder, a much better chance of getting back to normal and not having ongoing consequences in terms of bladder control and bladder health. And if you're having a catheter for a week, we will usually give antibiotics for that week to attempt to prevent urine infection during that time, because having a foreign body, having that catheter tube in the bladder, is a risk of potentially introducing infection. So we will cover that. So we will give women tips about how to pass urine, perhaps passing urine in the bath or in the shower to start off with. And it's not unusual to have difficulties passing urine, either because perhaps there's pain after the birth, or pain from stitches, or possibly a bit of constipation, or because of issues during labour. And these first couple of voids, so the first couple of times you empty your bladder after having your baby, it's really important for us to look out for how much you've passed, how long after a catheter was removed or you gave birth it was passed, and for us to make sure that things are going well. So, zesty bit. My zesty bit for midwives is a bit like the fluid balance last week. Don't overlook the bladder. It's simple, but it's essential, basic labour care. And that doesn't mean lots of catheterisations, but that does mean talking to a woman about, has she emptied her bladder? How much has she emptied? Did she feel that it felt like she fully emptied it? and keeping a very close eye on that during labour. And if we are catheterising, to be careful and do it with aseptic technique so that we are making sure we're cleanly catheterising and not introducing infection, and being aware that it's an uncomfortable procedure. So explaining to the woman carefully what we're doing and trying to do it as gently as possible to avoid trauma, because it's uncomfortable and painful. And if you're a woman, understand that you might have a catheter in labour. A lot of women will have a catheter in labour. If you're having a caesarean, you will definitely have a catheter, because it's important to keep the bladder empty so we can operate on the womb where we need to anatomically be. So understand what a catheter is, why it's important, and that you may well have one in labour. Or if you don't have one in labour, you may well be asked to go and pass urine, measure how much urine you're passing. And all this is to try and maintain your long-term bladder health and make sure that you don't experience problems with your bladder in labour that could cause you longer-term problems in the future. I very much hope you found this episode of the theobspod interesting. If you have, it'd be fantastic if you could subscribe, rate and review on whatever platform you find your podcasts, as well as recommending the theobspod to anyone you think might find it interesting. There's also tons of episodes to explore in my back catalogue, from clinical topics, my career and journey as an obstetrician, and life in the NHS more generally. I'd like to assure women I care for that I take confidentiality very seriously and take great care not to use any patient identifiable information unless I have expressly asked the permission of the person involved on that rare occasion when it's been absolutely necessary. If you found this episode interesting and want to explore the subject a little more deeply, don't forget to take a look at the programme notes where I've attached some links. If you want to get in touch to suggest topics for future episodes, you can find me at theobspod on Twitter and Instagram, and you can email me theobspod@gmail.com. Finally, it's very important to me to keep the theobspod free and accessible to as many people as possible. But it does cost me a very small amount to keep it going and keep it live on the internet. So if you've enjoyed my episodes and by chance you do have a tiny bit to spare, you can now contribute to keep the podcast going and keep it free via my link to buy me a coffee. Don't feel under any obligation, but if you'd like to contribute, you now can. Thank you for listening.